Hello everyone, this is Dr. Arif Khan. I'm a consultant pediatric neurologist working at American Center for Psychiatric Neurology and also Neurospinal Hospital. Today I'm going to talk to you about one of the most common neurological conditions in children called epilepsy. Now, I'll take you on a journey. So let's start off from a child's first seizure. Having your first seizure, or a child having a first seizure, is one of the most frightening events you would ever experience in your life. And we will just move from what does it mean to how it's diagnosed and how it's treated and what's the prognosis of the condition. The first thing that strikes you when you are faced with your child having a seizure in front of you is panic, sometimes fear, anxiety, and a sense of helplessness. So having a clear first-hand eyewitness account is absolutely important, because what will be discussed with you at the time of your clinical appointment with the doctor would be verbatim of what happened to your child when this occurred. And if possible, a video capture or a video of that particular event would be extremely useful in making the right diagnosis. Usually the diagnosis is quite straightforward, but many a times it can be difficult because there are many conditions that mimic epilepsy, that is, they look like epilepsy for someone who's seeing it for the first time, but actually are not. Some of the examples of this are breath holding spells in toddlers or young children. They can look like children having epilepsy, and I've seen lots of children who have wrongly been started on treatment for the same. Other conditions being febrile seizures, when children have temperature, they can throw a seizure, and by the time they're 6 years of age, they grow out of it, and that is not epilepsy. What are the different types of seizures usually? When you see an individual having a seizure, the common ones that you come across are what we call as generalized tonic-clonic seizures. That is, a child would maybe cry out, they fall suddenly onto the floor, their whole body is quite stiff, and then goes into a clonic movement, that is jerking movements which is rhythmical. And this can go on for 1 or 2 minutes, and sometimes for a longer time. And a child might become incontinent, that is, they basically wet themselves, they have tongue biting, and after the seizure stops, they're quite drowsy and sleepy, and this is the normal process by which a seizure completes its course. And that's the most common one that you would come across. The not so common ones are tonic seizures, where a child only becomes stiff, only clonic ones where there is no stiffening but just shaking, rhythmical shaking of all the limbs, or just one limb or one side of the body. There are other types of seizures also called as myoclonic jerks, where a child has intermittent jerks and they're not very frequent. Then there is absences, where you would see a child just going blank. Now, every time a child goes blank, it doesn't mean it's a seizure, and it has to be evaluated in a systematic fashion. And these episodes sometimes can be seizures or can be related to epilepsy, and it's called as absence seizures. Whichever the type of seizure, when you go to a clinician, with the help of the history and the first-hand eyewitness account, he or she deciphers as to what type of seizure your child has. What is important for you to know is, if your child were to have a seizure for the first time, what you should do. The initial instinct for any parent or any bystander is to try and stop a child from having a seizure. But the bottom line is, you cannot. Nobody can stop the seizure of a child by doing anything that's possible, except if there is a medication that can be given to the child which has been prescribed by a doctor. So the main aim, if you have a child having a seizure in front of you, is to make sure that you keep the child safe and let the seizure take its own course. And also make sure you call for help in the form of an ambulance, paramedic, a doctor, whoever it's possible. You keep the child on the left lateral side, that is to their side, so that all the secretions, and if there is blood in the mouth, that can be drained out, and it doesn't go into the airway and cause problems. Do not try to hold them and try to stop the seizure itself, because it's not possible, and you might cause more damage than benefit for the child, because sometimes I've known children who've suffered bone fractures because someone was trying to stop their seizure. Don't put anything in the mouth, and don't try to put your finger or an object in the mouth to remove anything. And some children who've been diagnosed with epilepsy and have recurrent seizures, we prescribe them what is called as rescue medication, which can either be given rectally, that is through the bottom, or buccally, that is inside the mouth. But parents have to be appropriately trained to do this. The next question that needs addressing in a newly diagnosed child with epilepsy is, why did my child have a seizure? Usually, all of us are allowed to have one seizure, and many of us have one seizure and never have it again. Now, that is not epilepsy. The basic definition of epilepsy is he or she should have 2 unprovoked epileptic seizures. What I mean by unprovoked is not related to a temperature or a disturbance in the salts in the body or because of an infection and so forth. It has to be unprovoked. Then you can give, if the child has 2 unprovoked seizures, then a diagnosis of epilepsy could be considered, but provided it's been evaluated by a doctor who has the expertise to do it. The next area of discussion with parents usually is, what is the cause, or why did my child have a seizure, or why my child has a diagnosis of epilepsy? And many times the cause of epilepsy is not known. And actually 60% of the times, the exact cause of the epilepsy is not known. And most of these conditions are usually genetic, or there is an underlying genetic cause. But because our genetic science, or the understanding of the genetic basis is at a very early stage, we're not able to make a specific diagnosis. But with technology and with the advances that we're making in this area, things are changing. The doctor will ask you many questions. The doctor will assess what's the background, the history, and so forth. And based on the age, the type of seizure, and the EEG findings, the doctor puts in a differential diagnosis. And we should remember that epilepsy per se is not a single diagnosis. It is a group of conditions. And under epilepsy, you have about 20 to 30 different epileptic syndromes. And the aim of the neurologist or the pediatrician should be to identify what specific syndrome your child has. So in 60% of the patients or children, we are not able to specify why the child, or what is the cause behind the child's seizure. But in the remaining, there is an identifiable cause, like a previous scar on the brain secondary to meningitis that the child had many years ago, a head trauma which led to a scar in the brain, or birth injury that child might have sustained at the time of birth. The child might have a metabolic disorder, and so forth. And this has to be looked into in detail to identify if there is a cause that can be picked up. Going on to tests. Many a times your doctor will, or a neurologist that you see, would advise a number of tests. Usually the diagnosis of epilepsy is clinical. Now the various tests are arranged to understand the epilepsy better, also to find out the underlying cause of your child's seizures, and also to find out if there is any other metabolic condition or disturbance in the salt level in the blood that is causing your child to have seizures. And for this, your doctor might ask you to arrange an EEG, which is a test by which electrical activity of the brain is studied. They might ask you to arrange an MRI scan, which is a detailed scan of the brain to look at the structure of the brain as such. And they might ask you to get some blood tests done. This is a complete evaluation of a newly diagnosed child with epilepsy. What I mean by EEG is that a child is brought in to an EEG lab. Sometimes if the child is older than 7 or 8 years of age, they can have it straight away, but in younger children we tend to either bring them by sleep deprivation, that is making sure that they are quite tired by the time they come to the lab and put them to sleep, and sometimes we give them a little bit of sedation to put them into sleep with medication. And this is because the child has to remain still when the study is being done. So some stickers or leads are put onto the scalp in different areas, and the electrical activity of the brain is studied on a computer. Now this is not an invasive test, it does not cause any harm to the child, and it does not have any long-term side effects. The test results are printed out or stored on a computer, and are analyzed by an expert like a neurologist or a neurophysiologist. An MRI scan is a test that is usually done to look at the structure of the brain. It's basically a test using a magnetic technology by which the structure of the brain is seen. It takes about 40 to 45 minutes to do, and sometimes younger children are put to sleep to do it. And it's quite a safe test, unlike some of the radiological tests which are radiation based. Once an appropriate and correct diagnosis of epilepsy is made, the next step is to ascertain what would be the best treatment strategy for your child. And usually anti-epileptic medications are used. There are more than 30 different anti-epileptic medications that are in the market, but there are 4 or 5 which are used very commonly. You would hear the names such as sodium valproate, lamotrigine, carbamazepine, clonazepam, and these are all different anti-epileptic medication. Some of the older ones like phenytoin and phenobarbital, and each of these have a number of brand names. Like sodium valproate is called Depakin here in Dubai, most of the times that is. Lamotrigine is called Lamictal, carbamazepine is called Tegretol, and so forth. But in the right hands, like with a clinician who is aware and who has the competency of managing epilepsy, appropriate medication needs to be started, and in many children, that is close to 50% of them, the seizures can be controlled with the use of one medication. However, if the seizures are not controlled, then we go on to the second medication. And with a combination of 2 medications, you're likely to achieve seizure control in about 60-65% of children. But there always remains 1/3 of children with epilepsy in whom the epilepsy is refractory to treatment. That means that in spite of using a number of medications, we will not be able to control their seizures. And for this reason, most of the research, most of the resources in research has been attributed to this area. And there are many other alternative forms of treatment that have been introduced over the last few decades. Ketogenic diet, which is a high-fat, low-carbohydrate diet, has been introduced with a lot of success. A vagal nerve stimulator, where a small device is inserted inside the skin, the chest here, and it passes impulses to the vagal nerve and somehow tries to control the seizures, but it's a surgical intervention. And the third option is surgeries, brain surgeries, which are much more elaborate and need more evaluation. But the main aim is to give the child the best quality of life and the best chance of achieving their educational potential and intellectual potential by controlling their seizures to the best possible extent. The main aim is to make them seizure free, but if not possible, then it's to control it to the best that we can. So the treatment has to be tailored, it has to be titrated. Every medication has to be started from a small dose to make sure the child tolerates it, and then slowly built up with regular follow-ups. And the children that we control the seizures quite easily tend to have a very good outcome. And if they have specific syndromes which are the so-called benign epilepsies, which obviously we shouldn't use those words as benign. None of the epilepsies are benign, but the less severe ones, they tend to have very good outcome. They do really well at school, and they make friends. They go on to various professions. But an important message that has to be carried by the parents, for the school, for the relatives, for the friends of the child, is that the child with a diagnosis of epilepsy should be treated in the same fashion as their siblings, as their peers. They're not any different. They should be encouraged to take part in all the activities, all events that occur at school. However, in some areas they have to be a little careful. For example, if a child is going for swimming, they can go and swim. Yes, the child can have a seizure in the water, but the lifeguard who's there needs to be aware that the child has a diagnosis of epilepsy and they need to stay outside the water. A child with epilepsy can go cycling, they can play football, they can play cricket, they can go marathon running, and anything that any other child could do. And as they grow up and become teenagers, they need to take more ownership of their condition. What I mean by ownership is that they need to realize and understand what triggers their seizures. They need to remember to take their medication on time. They need to remember to attend their follow-up clinics on time. And they have to comply with their anti-epileptic medication. And I would like to end this short video by saying that there are many misconceptions, misunderstandings and misinformation about epilepsy. And this collection of misinformation is the biggest threat to the identity of the child. And not only the identity, the self-esteem of the child, the security of the child, and the opportunities that is offered to the child. And only education, and nothing but education, can protect them from this. And not education to the child itself, but education to the child's parents, education to the school, and education to general public as a whole.